Well, thanks so much for being here. I'm Erica Armstrong. And my goal is to explain from a clinical perspective where the costs from chronic conditions are coming from and why every self-funded employer is actually paying for chronic disease twice. I hope that you leave here today with some new ideas about designing your health plan or even how to evaluate different vendor solutions. A little about my background. I was a practicing family medicine physician. You can see in my young, eager years as patients were lined up. This was a good day because I think I only had one person lined up in each room, and I had about on average 8 minutes to solve multiple problems, which at the time I thought were individual problems. And eventually, I came to my own conclusion that maybe what I was doing wasn't truly solving the issue, but rather delaying the progression of disease. And the other pattern I noticed was that conventional medicine is very specialty driven. Of course, we need our specialists, but a lot of times in primary care, you send many different referrals to different doctors for every body part. And at the end of this, a lot of times my patients would come back to me and say, well, I had these tests, I had this procedure, I'm on these meds, I don't feel that much better, and nobody actually told me why any of this was happening. And I actually heard that so many times that I looked for a different approach to solve their problems. And I found functional medicine, which at its core is finding and treating root causes. We started a functional medicine business as a doctor and dietitian duo that is now a national functional medicine benefit for employers. So you will hear this theme of the talk, that solely managing symptoms and not addressing root causes is leading to paying for chronic conditions twice. So where do those two payments come from? One, managing the disease. Managing the disease itself is expensive, and I'll show you some common conditions and how much they cost to manage. But you have your medications, you have your visits, your specialist referrals, your imaging, your procedures, even monitoring and devices, as well as supplies. And then you have the complications that are there because the root cause has not been addressed. So that means there's still a risk there that has not been eliminated. And so that could be anything from inpatient admissions, surgeries, or even therapy escalation, adding the dosages or adding more medications to get the same result. And then the side effects of those. And the big thing that I'm going to talk about today is that downstream effects happen. When you don't treat the root cause, things that are related to that root cause will develop over the years as well. This is a big deal because it's 90% of your healthcare costs. They're coming from chronic conditions. So this is a definite, if you're having any issues with your spend, look for chronic conditions. These are the big ones that we see at Root. And metabolic, no one would argue with that. It's a huge issue between even the medications, but also kind of the imaging and workups that you need and the specialist visits. And this is on average $11,000 to $15,000 a year. The interesting thing about this is there's no end in sight. When you sign up to manage disease this way, you are going to be paying at least this every single year over year. This is meant to just be continually managed, and it will eventually escalate in cost. With autoimmune, this is one of the areas we're actually most helpful with at Root. The biologics alone, on average, actually about $72,000 a year. Of course, people aren't usually paying sticker price with that for some other solutions you've all come up with. But they can still be very costly, and not only the medications, but the time off work, the infusions, and the specialist visits and imaging. Lastly, migraine. This is one that not many people think of because there is a hidden cost in absenteeism and presenteeism, in addition to those both preventative and acute medications, sometimes MRIs, sometimes neurology consults, and ER visits. So I was in this loop. I was in this loop for years, actually, and I was showing the picture in the beginning. But what typically will happen in a short 8-minute visit is that you don't have time to investigate it or put the whole picture together for people. So that ends up in two main solutions, which are medication and referral. 33% of primary care visits in the conventional system end up in a referral at the end of the visit, just to put that in perspective. From there, if you're not better, you follow up with your PCP, and then you may try a second medication. You may be told to monitor this at home because there's not really anything in between visits for support in conventional healthcare, and so you may be told to follow up with your own self-monitoring. Of course, this isn't anyone's fault. This is how the system is set up. Primary care has a huge scope, very, very broad scope, and should try to manage a lot of different things in short visits. And then the incentives are not aligned. In a fee-for-service system, people are paid for more and more volume and more utilization. And then these are the main tools that we have at our disposal that are quick and we can do in 8 minutes. So let's give credit where management is where it's due. Management does stabilize disease. Controlling your blood pressure could prevent a stroke. Yes, we still need to do this. I'm not taking that out of the equation. However, if the risk is still there, it's not removing the cause, and so sometimes the dose climbs, drugs are added, and complications still occur, and you pay regardless of the outcome. You keep paying that same fee to manage the disease. So the second payment is coming because disease is still there. So that could either be complications of the disease itself. We all know that diabetes can lead to kidney disease and nerve issues. Autoimmune, you may be getting escalating new biologic therapies, and so on. But source two could be actually complications of the treatment. The treatment itself has side effects, sometimes pretty serious side effects, as well as leading to other downstream effects from those side effects. So you might ask, some of those complications are not going to happen while my people are employed. And you're right, some of them will not happen, but things are happening in year one that you're currently paying for. And those are things like ER visits, dose escalation, absence, and presenteeism, even short-term disability or dose escalation. So there are many, many costs in year one that we actually have seen be reversed within the first year. So you've probably tried all of these solutions. Most of these are focused on the cost, the price part of the cost, and a little bit on utilization. And so the natural next step, if your costs are still rising, is to target utilization. We have to fix that at the root cause. So this is a new category we created at Root. We call it Root Cause Health Benefits. We sit right alongside the health plan. We layer very nicely over DPC as chronic condition specialists. And we take an old way of siloed condition management in a different app for every different body part that don't talk, and create one integrated system where we consider the body as it is, communicating systems. And we take the old way of just paying for the same thing and actually provide real clinical validation and proof. This is an illustration, just briefly, if you're not familiar with functional medicine. We're looking to turn off that faucet. We're looking to turn off the root cause. So let's take a very, very common symptom, heartburn or acid reflux. Most often this is mentioned at the end of a visit, and so you're often just given a script for a PPI medication and sent on your way. And sometimes we do need those medications, right? They can prevent complications, but the bigger picture may have been missed. And that could be, what was actually driving that? Was it an infection in the stomach lining? H. pylori is very common and not usually screened for. Is it a food sensitivity? Or at the extreme of that, is it a gluten sensitivity or a celiac disease, which is an autoimmune condition? Autoimmune disease, on average, takes 7 years to make a diagnosis. And that is because our system is not looking for root causes. How do we do this at scale? It seems very personalized and individualized, and we're digging deeper, right? And it's one of the big reasons that functional medicine has not been scalable. So we start with screening the entire organization. So we get people engaged, and then we take the people who need our help the most and work with them one-on-one via telehealth and extended visits. We have 45-minute visits with our doctors and dietitians, and this is all powered on our technology platform, which makes it easy for employers to work with us and for everything from onboarding to reporting. And so here are 5 common cost drivers in chronic conditions. They share root causes. Often that's an inflammatory burden, whether or not that's coming from the gut microbiome, or metabolic dysfunction like insulin resistance, which is present in over half of people. So functional medicine needs real infrastructure to scale. Even at 200 lives, most functional medicine clinics are very, very small. Usually less than 150 patients are in one clinic. And that is because it's very, very difficult to scale without a system and without a team around you. And so these are the way that we have been able to work with very large employers is by standardizing and validating our clinical protocols, by having our own core processes and training for our MD and dietitian teams, a technology platform, and then the data that we need. What this looks like for a real person, this is an HR director, actually, who shared her story on her podcast. But she came to us on actually 2 or 3 different autoimmune medications, and her feet hurt so bad she couldn't put her shoes on to take her kids to school when she started. By 6 months, not only was she completely pain-free, but we had lowered her laboratory markers to the point the rheumatologist felt comfortable that she could come off of her autoimmune med. For this person, it restored her whole quality of life, and for her employer, it saved $96,000 a year. So that's just one person's result. So what does root cause resolution truly look like? Your symptoms are resolved at the root cause, which means complication events are none. Your medications are sometimes, not always, discontinued, but a lot of times they are, and I'll show you some stats on that. And the specialty visits are reduced. There's no more bounce around. You have clear answers. Going back to the original slide, what is the cost difference? $15K a year over year, or $1,000 for metabolic? You can see with these drastic cost differences between ongoing management and reversing it that we actually only need 2% of the entire organization to have a positive outcome like this to pay for everyone. Why does that work? Number one, we stop the specialist bounce around and all of the downstream effects of that. We prevent visits from sometimes things that end up in more expensive things like procedures and medications. And we also have a goal to reverse conditions, which naturally can lower things like diabetes by $19,000 a year. And then we off-ramp medication. Even though we're licensed physicians and can and do prescribe medication, our first line is nutrition, and that's why every member has a dietitian. When we solve root causes, the medications naturally come off. This has actually been validated by the Validation Institute in a cohort of autoimmune patients. We were actually able to get them completely off of their medication within the first year, 27% of the time. That doesn't happen in conventional medicine. It almost never happens. Somebody already posed a really, really great question on the app, and I saw it ahead of time and made a whole slide around it. I think this might be the most important slide of the whole thing, right? Because when your costs are going up every year, you don't want to add one more cost, right? You're already stretched thin, but the cost of doing nothing is so much worse. Just think about one person with insulin resistance. In that first year, this person could be costing you 8 times what they are now. And if they do happen to have one of those acute events, 30 to 130 times what they're costing you now. We actually used a couple of our own employers' data to give some examples here on the right. And so when we screened the entire organization, for the top organization, we found a lot of insulin resistance and other markers. And for the second organization, these are 2 different industries, by the way. The first one is manufacturing and the second one is finance. And these are the things that we found that if left untreated would lead to, on average, between $3,000 and $12,000 per member per year additionally. So that's averaged out. Some people are costing more if we don't take care of this, and some people are costing less. So my take homes here in what we see at Root is that when you're evaluating a solution, outcomes are so much more important than engagement. I would say the number one hesitation is, how are you going to get to my people to change? And I would say we don't need everyone to change. They will, we've seen it, but we need like 2% of people to have a really great outcome. And those people are already motivated because they're not feeling well and they want a new, different way to look at things. You also want a strategic partner over a point solution. You want someone who can work with the whole organization and find those people for you. You don't want to have to be singling out people and trying to get them to act on their own. Let us do that work for you. Lastly, you want a benefit that looks to stop the spend year over year for people, not just continue to manage it every year. And so self-funded employers can't cut their way out of chronic costs. You have to reverse your way out. We do lots of analyses for companies to see what part of your health spend can we actually reverse. If you'd like that done for your company, this is a QR code. You can schedule a call and we'll review that with you. We're also here at our booth 214. Let's see how I'm doing on time. Not too bad. I do have some additional slides on member journeys we could go over if anyone is interested, but I'll start with the questions to make sure we can go through those. I think I answered the first ones that I pinned already in the slides, so thank you for whoever sent those in. Do we consider musculoskeletal to be part of chronic disease? Absolutely. This is driven mostly by inflammation, and so when we lower inflammation, people's joint pain is actually one of the things that gets better earlier on, especially when we focus on gut health. Is this plan consistent for sponsors who carve out from, okay, yeah, PBMs are a great way to control your pharmacy cost strategy. I would say we just add to that. We add to that because there's naturally less prescribing that happens. How soon do you think until we have key metrics for GLP-1s? I would say we already have these for certain individuals. They've been shown to prevent heart disease. However, I do think there's a lot of lack of individualization for why people are on the meds to see if the indications for them will truly create ROI. The other problem is that 45% of people will be off the med within 1 year. We know this has been in large studies. And so what happens if you've been on the med, we also know that 60% of what you lose is lean mass. That's what drives your metabolism, actually. So if we have someone on this medication and we know like almost half of them are going to go off and we don't also have a nutrition component, are we setting this person up for long-term success? I would argue no, they might even be worse off because now they don't have their muscles to increase their metabolism. So very important if you're offering GLP-1s to also have a nutrition component so we can make sure people are strength training, eating enough protein, and so forth. How do you drive employee engagement with chronic condition care solutions that the employer is already paying for? There's probably two different ways I can answer that. One is people do have a great relationship with our doctors and dietitians because they have the consistent care team, and we tend to know a lot about the whole employer account. And so we can be an advocate for those. But the other unpopular answer probably is that we can replace them because you don't actually need 3 different point solutions. You might need one that can connect them. Okay. How often do you run across issues working with specialists to deprescribe expensive biologics or infusions? Almost never. This might be surprising because that is their toolkit. What every doctor at the end of the day wants to see is their patient happy and healthy. And when that happens, it's hard to argue with. The other thing is we have data. And so a lot of times rheumatologic med decisions are based on your actual inflammatory markers, and we can provide that for them so that the conversation is easy. What are some labs that are not commonly ordered in traditional medicine that need to be ordered to understand optimal health and diagnose root causes of disease? Love that question, thank you. A couple of key ones I would mention. We find so much vitamin D deficiency. This should be covered, it's just not covered as a screening lab. It's really expensive, sometimes like $150 for one lab. That's why it's not ordered. But we can really adjust the dose if we know that. The second I'll say is an insulin level. Insulin levels rise about 5 years before blood sugars rise. So if we want to catch people and prevent an 8 times increase, we need to know that they have a problem now with an insulin level. Lastly is an HSCRP. Not only is this a risk heart disease marker, but it also is an inflammatory marker, and so we end up screening and catching a lot of autoimmune disease that actually hasn't even been diagnosed by screening for that. What is the main driver when an employer says yes to root? Good question. I think it's 2 things. One, functional medicine has really never been covered before, especially at scale, in a validated way, and your people probably have been aware of functional medicine in the last couple of years, so they might be asking for it. The second is cost. I mean, we control the largest cost bucket with a solution that, so we can affect 90% of the cost with a solution that costs about 2% of your medical spend. And so I would say at the end of the day, for the CFOs in the room, the decision usually comes down to a solution that can control your costs. Okay, how do you get the employees engaged for the initial screening? What is the rate of engagement? Is this panel at Quest and LabCorp? We do have direct contracts with both Quest and LabCorp, so we can hit pretty much any city in the country. We don't really have any trouble with access to labs. I would say the number one thing is people are self-motivated to know their data, and so we don't really have much issue, and there's no friction because they don't have to attend an appointment first. They can just make a quick visit to the lab. So it depends on the industry. We have some accounts. I think our floor is about 22% of people have gone from one of our harder industries. We also have a couple of brokerages that are our clients, and they're up 80 to 90%. So good job, guys. You like the data. Okay, I think that we might be close on time. So okay. If anyone else wants to pop, oh, there's another one. What's your ability to scale to handle more employers or a health plan's member? Great question. We are actively scaling up. I think we have increased year over year about 400%. And so we are set for that. And a couple of the reasons is our technology platform is in a really great spot to help us scale up. And also the clinical protocols and training that we do for our clinicians is in a great spot as well. Do you have a minimum size group? About 100, less than 100 if you really want the benefit. It's a great nice to have. We just can't do a lot of the reporting because it's harder to anonymize under 100 people. $50 state coverage, yes. Great questions. Really appreciate all of your attention, and I see a lot of familiar faces, so I appreciate you coming in to support me. And yeah, thank you.